Mark Alexander. I'd like to welcome you to the Parkinson Support Group of Sonoma County's virtual meeting. Today we have Dr. Rima S. Dr. Ash is a movement disorder specialist at Kaiser Permanente San Francisco. Having completed a fellowship in movement disorders such as Parkinson's disease, essential tremor, and dystonia, Dr. Ash has had extensive training in the complexities of these conditions and in using deep brain stimulation and botulinum toxin. At Kaiser, she works with a multidisciplinary team of specialists to help provide the best care for her patients. She chose the subspecialty because of the complexity of diagnosis and because of the enormous progress that's made in the treatment of these disorders. And I have a disclosure to make. Dr. Ash has been my personal neurologist for almost 10 years. So now it is with my utmost pleasure, and as part of the Parkinson's Awareness Month, I asked Dr. Ash to unmute herself and give us a presentation on the mental challenges in Parkinson's disease.
Thanks so much, Mark, for inviting me today. I'm really glad to be able to speak with you guys virtually. I wanted to pick a topic that maybe is sometimes avoided in Parkinson's because it can be sort of a harder sort of topic to discuss, which are the mental challenges in Parkinson's. So what I hope today to do is to talk about a few of those mental health challenges. We might not get through everything, but I want to focus on psychosis, hallucinations, as well as depression, anxiety, and apathy. And then my hope is to keep the talk brief so we can spend a lot of time answering questions from all of you. We're going to start with a video just to talk that sort of points out psychosis and hallucinations in Parkinson's. It's about a 4-minute video. We'll start with that, and then we'll go ahead and do the PowerPoint.
Diagnosed with Parkinson's disease about 8 or 9 years ago. I noticed his gait seemed strange and that he wasn't swinging his arms when he was walking. And so I suggested we go to the doctor, and he suggested a neurologist. I didn't have much experience with Parkinson's disease, even with my nursing experience, and it frightened me. It frightened us. Last year, around this time, we were in Mexico. Mike went deep sea fishing with the couples that we went to Mexico with. And when he returned, by the way, with a big fish, I asked how it was, and he said, it was great. I had a good time, but the ice was melting. One of the wives who was with us looked at me, I looked at her, and we laughed, and we said to him, stop fooling around. It took him a long time to believe me when I said, we're in the Caribbean, there's no ice here. And I think he was embarrassed, I'm not sure, but everyone dropped the subject. And then it was over, and we didn't think that much about it. Actually, we forgot about it. There were many occasions where we would leave the house together, and he would say to me, are they coming with us? And I would say, who? The children. Mike, stop fooling around. I'm not fooling around. They're sitting right over there on the couch. And I would look him right in the eye, sometimes put my hands on him and say, honey, we're alone. We live alone here. The children are all gone. The movement disorder symptoms, difficulty putting a jacket on or getting out of a chair, I can help Michael with. But when he started hallucinating, it's so scary because there's nothing I can do. I was really frustrated and upset. And sometimes we even argued about it. In my nursing experience, I'd never come across it, and it was something we had to talk to the doctor about. We have a good life. We've created a life before and after the Parkinson's disease. We're trying to continue doing that. We'll go sit in the car by the beach or walk at the beach, go to the movies, go out to our favorite Japanese or Thai restaurant. We do a lot of things. We do family activities. Keeping a positive attitude with this disease is probably the only way you can handle it. And what makes it easier is that Michael doesn't complain about anything. So how can I? Nobody really knows the day-to-day challenges, and they're extremely difficult, frightening, and in particular, the hallucinations were almost the scariest part because you don't know what's going to happen. We're sharing the story because maybe other people will understand that they have to bring this to the attention of their doctor. This is part of Parkinson's and that there's something you can do about it.
So I just wanted to show that video just to introduce the first topic that we'll be talking about today, which is hallucinations and just sort of general psychosis in Parkinson's disease. So, when we think about Parkinson's disease, when one is initially diagnosed, there's so much concentration on the motor parts of the disease. So, all the things that most people are familiar with, tremor, slowness of movement, stiffness, walking changes. But as the disease changes, those things often are controlled or relatively controlled, but other things start to creep up that can be more difficult to control with the therapies that we use for the motor parts of Parkinson's. So we start to notice more problems with our bladder, like our autonomic dysfunction, for example, or we start to notice more problems with sleep. And then as the disease changes over time, we really start to have more trouble with, or many of us have more trouble with, the mental aspects of Parkinson's disease. And there can be a lot of this. So there can be anxiety, there can be depression, there can be apathy, there can be psychosis, which includes hallucinations. I won't talk about this in this talk, but there can also be a lot of cognitive decline, which is, sort of part of the psychosis and hallucinations that we see. So I wanted to concentrate on this just because it's not something that we tend to focus on for many, many years into the illness, but it's something that's important to touch base on because it becomes one of the most important parts of managing quality of life in Parkinson's disease. So just to go over what psychosis is, I tend to divide it into three different parts. One can have hallucinations, one can have delusions, and one can have paranoia. So, a hallucination is just a false perception of like seeing something, hearing something, even feeling something. Typically in Parkinson's disease, that's a visual hallucination. What I hear the most are people noticing maybe that there's something in the periphery of their vision. Just a quick sort of glimpse of a person there or an animal there. And then when they look at it, it's gone. And that's typically what we see initially, or they see patterns on the floor. So they might think that there's spiders on the floor if the floor has dots on it, for example. There can also be presence hallucinations, and these are hallucinations of people. Again, typically quite fleeting. There might be a coat rack, and someone might mistake the coat rack for a person really briefly, and then they look at it again, then they realize it's just a coat rack. Okay. Then there are delusions. So delusions is sort of a fixed conviction that something is real when it actually isn't. I have a specific patient who is convinced that they have a smell about them, for example. They don't smell bad, but they have a fixed delusion that they have a smell because of their Parkinson's disease, and that everyone around them can smell this bad odor. So that's an example. Or someone may feel like this isn't really their house, and they're really focused on that. Okay. Thirdly, one can have paranoia, and this can be quite difficult, especially for caregivers, because often the paranoia might be geared towards a caregiver. So sometimes a person might have a fear that their caregiver is poisoning them or trying to hurt them, when in fact, they're just, of course, trying to help them and care for them. And so that can, obviously make the disease process much harder to deal with and make caregiving very difficult as well. So how often does psychosis happen? Well, in later stages of Parkinson's, and especially in those who will develop cognitive decline, so in those who will have dementia, up to 50% of people can have some hallucinations. Again, as I mentioned before, they're typically visual, and luckily they're very rarely frightening. So I actually have patients who, believe it or not, enjoy their hallucinations. So I recall having a patient who was a poet, and the patient used to see children in his front yard. And he loved seeing these kids. He thought it made him feel happy. And so I mention this because we're not going to treat that. If that is not interfering with quality of life, then we're not going to treat it. I tend to treat it if it's interfering with quality of life, if it's frightening, if it's preventing someone from doing something else. But again, luckily, typically these hallucinations are not frightening for people with Parkinson's. And secondly, a lot of these hallucinations happen in the context of medication changes. So, and I'll talk about that in greater detail soon. It could be because one increased their Cinemet or any kind of their, any of their Parkinson's therapies, because dopamine, which is what we mainly take for our Parkinson's, is what causes hallucinations. So there can be a fine line between improving your motor symptoms and causing hallucinations as well. So if we're able to reduce those medications, we can often reduce hallucinations. So what are these medications? Again, I mentioned the dopaminergic medications. So again, that's any of the Parkinson's medications, whether it's Cinemet, Rytary, Requip, Mirapex, Azalex, Selegiline, all of them are helping you because they're giving you more dopamine. And by doing so, in some people, that can cause more hallucinations. There are other types of medications that can increase hallucinations and or confusion as well. One of the main ones that a lot of people with Parkinson's are on are the anticholinergics because of the urinary problems that people have with Parkinson's. So ditropan, oxybutynin is a common one that people might be on that can sometimes cause hallucinations. There's other ones like Cinctura that may do it less so, but it can happen. And then there's some other medications that I don't use very much, but like Artane, for example, can be used for tremor, but I tend not to use it because it so commonly causes hallucinations. Even Zantac, which is an over-the-counter, reflux medication, could cause hallucinations. So in addition to that, there's certain antibiotics that can cause hallucinations. If you have to be put on prednisone for other conditions, that can also make anyone hallucinate. And then, of course, I mean, if you're using cocaine or meth, you're going to hallucinate. So, as I mentioned before, hallucinations tend to happen more in those who have underlying cognitive impairments. So if someone has dementia, they're more likely to have hallucinations as well, but it doesn't always have to be the case. People can also have hallucinations if they're under medical stress. So if one goes to the hospital because they need a knee replacement, that in itself can just throw their brains off a little bit and make them hallucinate while they're in the hospital or while they're recovering from like their original illness. Hallucinations often happen in low light situations. And this can be a problem because as we get older, we can have more problems with our vision to begin with. So if one has cataracts, for example, or low vision, they're going to be more prone to getting visual hallucinations. So the more that you can keep your house bright, that can be sometimes more helpful to reduce visual hallucinations. As I mentioned before, hallucinations often happen in the periphery of the vision. The reason is our eye movements aren't moving as quickly, and it's harder for us to see things, or it's harder for our brains to acknowledge what's in that periphery. So it tends to make things up a little bit and therefore cause a hallucination in that periphery of the vision. For most people, if they look at that object a second time, the hallucination goes away. In more severe situations, people might try and touch the hallucination, and they'll typically just poof away. For some reason, people who, Parkinson's patients who see people as their hallucination, they tend to be small people, little people, whether that's a child or just a small adult. I don't know why that's the case, but I so often hear that they're seeing little people. Sometimes it can be, disturbing. They're trying to go to sleep and you might feel like there's 3 other people in your bed. And so again, if that's happening and it's disturbing, then that might suggest that we need to consider some treatment for them. So this is just sort of a picture of what one might experience. So this is a Parkinson's patient sitting at the table. And if he has visual hallucinations, he might see these people that are, and even a cat or an animal, and they're not there, but they're just hanging out with them. They usually don't talk to you, but they're there. So again, these are called presence hallucinations. So other things that can contribute to hallucinations are things as simple as constipation, which, many people with Parkinson's deal with. If you get really constipated, your whole body can just sort of not work very well. And one can have hallucinations just from that. If you're not sleeping well for many nights, you can hallucinate. If you get a urinary tract infection, that's a very common reason to hallucinate. If you have, a change in your electrolytes. So what does that mean? So if your sodium or your calcium or your potassium is off, that can also cause you to hallucinate. So typically, if someone initially has a hallucination out of the blue, the first thing that we will do is ask them to see their medical doctor to make sure there's not an obvious cause to why they're having those hallucinations. So one will always check your urine. They'll check some blood work to make sure you don't have an infection so that those things can be treated. And in turn, the hallucinations will improve after that. And the other thing to say is, as I already mentioned, if your vision is getting poor, you're going to be more prone to hallucinations. Same thing if your hearing is getting poor, you're going to be more prone to hallucinations because your brain is trying to interpret sort of low hearing, and they'll sort of make sounds up as they're doing so. So what can we do to reduce hallucinations day to day? As I mentioned before, good lighting can be quite helpful. Hallucinations often happen in the evening time because of low light, and just because the evening tends to be harder in general. And if you can just sort of give stimulating activities during that time, that can also be quite helpful. Okay, I'm going to pause one moment. My son is talking. Gotta be quiet, okay? So this can be really hard for caregivers in particular. And it's as much as you can, it's really important to try to reassure the patient and validate their experience. So rather than saying, there's no one here, or for example, there's no cat here, instead say, oh yeah, I'll take that cat outside now. Or yeah, we're going to say bye to our friend who's in the room now. So again, try to validate what they're seeing, and then act out the experience with them so that there can be sort of less tension with regards to that hallucination. It's hard to do, but it can help with the caregiver-patient relationship. So what can we use to treat hallucinations? As I already mentioned, all of us will treat these at different stages. I tend to not treat them unless they're bothering the patient. So if someone is seeing little children in their front yard and it's not interfering with their lives, and if they're writing beautiful poetry about it, go for it. But it can sometimes be disturbing as well. So because these often happen in people who have memory impairment, I'll try to initially give them a medication that helps their memory, which will in turn potentially help reduce their hallucinations. So I'll tend to use something like the cholinesterase inhibitors first, or Namenda. The two most common cholinesterase inhibitors that are used are Aricept and rivastigmine. Namenda is another memory medication that can be added to the cholinesterase inhibitors as well. Those meds often help, but they can have a paradoxical reaction sometimes. So sometimes people will actually have more hallucinations on them. So it's as with every med in Parkinson's, it's always about trial and error. You got to try something, see if it works, see if it doesn't work, and then try the next thing. So what is the next thing? So it's tricky. Meds in general that are used to treat hallucinations or psychosis for anyone block dopamine. And that's the last thing we want to do in Parkinson's, right? We already have deficiencies in dopamine. So if we block them more, we might reduce the hallucinations, but that's going to be potentially at the expense of slowness, of movement, stiffness, problems with balance and walking. So we want to try to use medications that don't do that very much. So Seroquel is considered an antipsychotic and is considered a dopamine blocker. However, at the doses we use, it does not really block dopamine. So we tend to suggest Seroquel at very low doses, maybe starting at 12.5 milligrams, and never up to more than 100 milligrams. And the reason we don't want one to take more than 100 milligrams is because after 100 milligrams, it will start to block dopamine and worsen your Parkinson's disease. Okay. I mean, this isn't without other potential side effects. Seroquel can be sedating, so it's typically taken at bedtime. And because it's so sedating, it could potentially increase risk of falls. So again, we want to use it only when we need to use it. There's sort of a newer medication called Nuplazid or pimavanserin. It's now been out, I don't know, maybe a little over 5 years. And it's a very interesting mechanism of action. It is an antipsychotic, but it does not block dopamine at all. So it has a weird term. It's called a reverse serotonin agonist. So it's somehow working on the serotonin serotonin pathway to help reduce hallucinations rather than the dopamine pathway. This is theoretically a great medication to use in people with Parkinson's. The one problem with it is that in some cases it has caused cardiac death. So again, we don't jump to using this medication. We want to use other things that have a better track record and don't have that black box warning of potential cardiac death. So, if someone has had cardiac arrhythmias or heart attacks, then we're probably never going to use this medication on them. And I have, some patients who are on it who it's been quite helpful for, but I also need to check, their EKGs, their heart ever so often to make sure it's not causing changes in their heart rhythm. Before pimavanserin came about, there was a medication called Clozaril that was being used for Parkinson's. Again, a very difficult medication to use. This is a medication that pretty much only psychiatrists would prescribe because you have to be part of a registry to give it. And the reason is if you're on that medication, it requires monthly blood draws because it can drop blood counts and cause a lot of other metabolic problems. So again, we only use it in dire situations when we have to use it. So for most of my patients who are having hallucinations, I'm typically going to have them on a dementia medication, such as Aricept or rivastigmine or Namenda. And then in many cases, they will also be on Seroquel. I will say I probably have, I don't know, maybe 10 patients on Nuplazid, and that's over, I probably have 1,000 Parkinson's patients. So very small numbers of people that are using Nuplazid, although again, it can be quite helpful for those people when other things have failed. Again, also, what I didn't mention here is one of the first things I'll try to do is try to reduce medication. So, maybe reducing your Sinemet by a half tablet each dose, or stopping your dopamine agonist like Mirapex or Requip will automatically get rid of these hallucinations as well. All right, I do want to focus a couple minutes on the difference between a hallucination and REM behavior disorder. Because I think a lot of people, when I ask them if they're having hallucinations, they say yes, but what they're actually having is they're acting out their dreams. And from my standpoint, these are treated in somewhat different ways. So REM behavior disorder is a condition that many people with Parkinson's have. And pretty much if you guys know what REM sleep is, in a normal person, when they have REM sleep, their brain forces their body to not move. But in someone with Parkinson's disease and REM sleep, for whatever reason, the body really moves a lot. It doesn't shut down. And so people tend to act their dreams out, like literally act their dreams out. I've had patients, pretend they're playing basketball and hit their head on the headboard because they think they're like playing, or, there's cases of patients, hitting their bed partner because they think they're like attacking a dragon. And their bed partner happens to be there as the dragon. But the distinction is that these are really happening within sleep or out of sleep. They are not happening when one is awake during the day. So you really want to separate those two. And the reason is this: people can have REM behavior disorder a decade before they develop Parkinson's. So it's not really related to like dementia and psychosis. It's another sort of pathology to Parkinson's disease. And people can have REM behavior disorder without Parkinson's disease as well. If someone has sleep apnea, for example, they can have REM behavior disorder. The treatments are somewhat different. We typically start with something, we want to reduce dopamine at bedtime because that can make you act out your dreams a little bit more. I'll try melatonin. And if it's really severe, meaning one is falling out of bed, hurting themselves or hurting their bed partner, then we might add Seroquel or even clonazepam. People can also have what we call hypnagogic and hypnopompic hallucinations. And these are hallucinations that specifically happen when one is falling asleep or when one is waking up. Again, they're associated with sleep. So I want to separate them from a true hallucination that's during the day. So the next time, if your doctor asks you, are you having hallucinations, make sure that you understand how to separate the two. All right, so we're going to shift and speak a little bit about depression and anxiety now. So we know that depression and anxiety are common in most chronic illnesses. And, it's always the question, like, is it because one has a chronic illness or is it part of the illness itself? We think that in Parkinson's disease, depression and anxiety are part of the illness itself. And there's a few sort of reasons why that's the case. A lot of people feel like depression and anxiety are a premotor feature of Parkinson's. So before one develops motor symptoms of Parkinson's disease, one might start to have depression or anxiety 5-10 years before they get actually diagnosed with Parkinson's disease. And this is because you're losing neurochemicals in your brain that help reduce anxiety and depression. So you're losing dopamine, you're losing norepinephrine and serotonin as well. And those are helpful in regulating your mood and your energy and your appetite and your sleep and the motivation and how you feel. Depression and anxiety can be very debilitating for people, and they can often, in some studies, it's shown that they're more debilitating than the motor symptoms of Parkinson's disease. But we often don't concentrate on them very much. So at least 50% of people with Parkinson's will at some point have depression or anxiety. And as I already mentioned, it is considered a premotor feature of Parkinson's, so happening before one is actually diagnosed with Parkinson's disease. So how do we treat anxiety and depression? Well, it's the best approach, although it's maybe not the easiest approach, but the best approach is to have like sort of a multidisciplinary approach to treating this. So an antidepressant might be helpful, but you also need to keep up with social engagements, support groups. Exercise can also reduce depression and anxiety. And therapy can also be really helpful in these conditions. It's tricky. It's sometimes hard to get therapy. And it's hard to get ongoing therapy, but it can be so helpful if it's available to you. We also know that if people have more motor fluctuations, especially off periods and freezing of gait, that can be very anxiety provoking and cause a lot of depression as well. So sometimes if we can improve the motor fluctuations and improve those off periods, then anxiety and depression can also improve a little bit. There's so many antidepressants that can be used for Parkinson's, and there's no great studies saying that there's one that's specifically good for Parkinson's or not. And so we really want to tailor the antidepressants to the patient. And so what do I mean by that? For example, if someone has Parkinson's and they're having depression and they're also having difficulty with sleep, I might choose an antidepressant that helps them with sleep as well. Or let's say they feel really fatigued during the day. Then I might choose an antidepressant that gives them a little more energy and helps their depression. So we really want to cater it to what the patient is experiencing. The same thing with tremor. Some of these SSRIs can worsen tremor. So we want to choose an antidepressant that may not worsen that. The other thing to mention is if you're taking an MAO-B inhibitor, so the most common MAO-B inhibitors are Azilect or Selegiline. If you're taking those, then there are certain antidepressants you cannot take, and there's certain doses of antidepressants that you also cannot be on. So that's really important to discuss with your primary care doctor or your neurologist or whoever is going to end up prescribing these antidepressants for you. So as I mentioned before, depression can affect up to 50% of people with Parkinson's, but 40% don't receive treatment. And I think potentially part of it is that it's not really talked about during the visit. The patient may not bring it up or think it's part of their Parkinson's disease. And the clinician may not concentrate on it because it's not a motor feature of the disease. So as I mentioned before, there's a ton of antidepressants that can be used for Parkinson's. There's not one that's better than the other. It's really geared towards the patient. So there's our basic SSRIs. So things like Celexa or Prozac, and then there's our non-SSRIs. So these are things like mirtazapine, Effexor, Wellbutrin. And again, they all can be helpful. It just depends on what the patient needs. There are also, non-medication ways to treat depression, in addition to therapy and exercise. We know that light therapy can sometimes be helpful. Acupuncture points, certain acupuncture points can also be helpful. And we know that being part of a community is extremely helpful for depression and Parkinson's disease. And so being part of a support group like this can be really helpful. All right, so a couple more slides and then we'll spend the rest of the time answering questions. I want to really briefly talk about apathy and fatigue, which I feel like are one of my least favorite parts of Parkinson's. I would say this and freezing of gait are what really sort of drive me crazy because I feel like they really interfere with quality of life. So what is apathy? Apathy is a lack of interest or motivation. It can be really frustrating for people with Parkinson's, and especially frustrating for caregivers who, really want their loved ones to get out there, exercise, do all these things to help their Parkinson's disease, but the patient is so apathetic that they can't really get moving and really don't feel any push to actually do these things that might help them. So there's no great treatments for apathy, unfortunately. In some situations, I'll try, again, the dementia medications. So Aricept or rivastigmine can sometimes be helpful. In rare situations, I'll even use stimulants. So these are like ADHD meds, Ritalin, Provigil, modafinil. But that's a very rare patient that is going to sort of do well with a stimulant for their apathy. So what can you do or your caregiver do to help reduce apathy and fatigue? If you have like a regimented schedule, that can be really helpful. Try to include things that you like to do, but it just more specifically, just have some regimented schedule within the day where, every day at these times, that you have to, like, this is your exercise time. This is the time that you go wash the dishes, or just something that sort of keeps your day moving along. Try to keep some goals for like achieving like your leisurely activities. Get out of the house, which is really important, and has been so hard with COVID. I think a lot of people with Parkinson's have developed a lot more apathy. I mean, I think people in general have developed more apathy with COVID, and getting out of the house just seems so much harder for a lot of people now, but it can be so helpful. Exercise, again, exercise helps with most everything in Parkinson's, right? So exercise can be really helpful for apathy as well. Obviously, you need to sleep well to feel well. So if you're able to, get the amount of sleep you need, and take a nap during the day too, to help you feel rejuvenated. And I think for caregivers specifically, very often a caregiver may interpret apathy as it's not part of like a disease process, but just like a personality trait in the patient, where now they're just being lazy, or they're just making excuses for doing these things, when really it's part of the syndrome itself. So I really liked this slide. I think it really sort of helped. Everyone is telling the patient, do this, exercise every day, get out there. And the patient's just like, I'm fatigued, I'm apathetic, I can't do these things. There needs to be a balance there, and we really need to sort of acknowledge that apathy is there, and try to be gentle in our approaches to motivate our patients and our loved ones.